We worked out some technical difficulties. As you can see, we've added a few components today, and so that required a little bit of extra double checking. I'd love to introduce our administrators today. We've got Matt Pontus, the CEO of Shasta County. Dr. Karen Ramstrom is our health officer. We've got Dr. Michael Vivakis joining us for the first time. He's our deputy health officer working on this event with us. We've got Sheriff Eric McGraney. Donnell Ewert is the director of the Shasta County Health and Human Services Agency. And Chief Brett Gouveia is not here in person, but he's here in spirit. He just checked in with us just a few minutes ago. He is the chief of CAL FIRE and Shasta County Fire Department. Do any of our administrators have any questions? Not any questions, anything to share with us? We sure the sound is still working. I'm hearing from upstairs that they had it for a second and they lost it. It looks good on your side? Okay. Okay. From our hospitals, we've got Robert Folden from Mercy Medical Center, Mark Mitchelson from Shasta Regional Medical Center, and Val Lakey from Mayors. And Robert, you had something to share with us today.
Yeah, good morning. So like Shasta Regional, we've adopted the universal masking as well. And the only real change is that we're asking anyone and everyone who comes into the building to wear a mask at all times, whether it's cloth or whether it's one of our procedure masks. Second, we met with our medical staff yesterday regarding our surge plan that we've been talking about. And we wanted to make sure that all of our medical staff leaders were on the same page with respect to that plan. So that was a very productive meeting. And then lastly, we still have one patient here in-house that's positive. And I do need to report today that yesterday, after we met, one of our patients that had been here in-house passed away. So that gentleman had been with us from the start, and you know, he battled COVID gallantly, and our physicians worked tirelessly, but he did pass away yesterday.
Okay, we're very sorry to hear that. I know that there was a Tehama County resident that had been reported to have passed away, and that's the person you're referring to?
Yes, yes. So he came to us through St. Elizabeth Hospital.
Okay, thank you. I just wanted to clarify that. Any of our other hospital folks have anything new to share with us today? Okay, so I'd like to introduce to all of you Daniel Walker. He is a supervising epidemiologist with us here at the Shasta County Health and Human Services Agency. He has been working very hard throughout this whole emergency response, and one of the things that he's been doing is studying the models that show what COVID-19 is doing and is going to potentially do. And I would like to turn it over to him now to explain the model that we are looking at right now. Take it away, Daniel.
All right, thank you so much. I appreciate it. So we've been looking at a lot of the different models and trying to best understand what different eventualities or projections and things like that could happen in our community, depending on the different interventions and different things that we put into place and how we respond to the cases and things that as they come into our community. So trying to best understand that, we've looked at a lot of the different models, and today we'll be sharing one of them with you, which is the COVID Act Now. So we'll go ahead and start looking at that one at this time. So at this time, you'll be able to see on the website, and this is the covidactnow.org. You can go there, and then you can go into state or into even our county. So right now we're looking at Shasta County specific data. And in this model, there's a couple different variations of how to look at what could potentially happen within our community, and looking at those restrictions and the stay-at-home orders that we are doing. So the main two that we'll be focusing on is a 3 months of stay-at-home lax, and then a 3-month stay-at-home strict. And I'll explain those a little bit more. So that stay-at-home lax definition would be voluntary shelter in place for high-risk groups, ban on events over 50 people, public advocacy around social distancing and enhanced hygiene, possible school closures, restricted travel, and passive monitoring, rolling out of population-wide testing and quarantine so that quarantines can be relaxed for those who are not infected. And then for the strict definition, that is a voluntary or voluntold shelter in place, community-wide home quarantine, especially firm for high-risk groups, shutdown of non-essential businesses, closed schools, ban on events over 10 people, passive monitoring, public advocacy around social distancing, and enhanced hygiene. Possibly closed national borders or restricted travel, public aid relief bill, rollout of free population-wide testing, and quarantine that so that quarantines can be relaxed for those who are not infected. So I would say that our current stay-at-home order that we are practicing in California as well in Shasta County kind of falls a little bit in between those two, a little bit more closer to the strict line, and that's kind of what we've seen with our data and our cases, how they've come in and how they've how we're seeing them in our hospitalizations and things like that. So with this, the strict stay-at-home would kind of estimate that around 2% of the population would become infected, and that we would never overwhelm our hospitals. And then whereas the lax stay-at-home order, it would estimate that around 43% of our population would become infected, and that around June 16th is when we would then become overloaded. And so I will move up now to the actual chart that is showing these. So first we'll talk about just this lax stay-at-home. So it's showing us kind of here today. So far we've had, I believe, 10 hospitalizations total. And then, some of those have been discharged as they've recovered and or passed away. But as you can see, that if we were to be more lax than we are, that the hospitalizations would continue to increase at an exponential rate. And by that June 16th time period, we would become overrun in Shasta County in our hospitals to be able to handle the amount of hospitalizations that would occur at that time. Again, these are just projections and things that we're looking at and trying to best understand our community. But if you look more at this stay-at-home more strict, is what we've kind of been seeing in our community, because not only are we practicing these stay-at-home measures in our community, but throughout the whole state of California, making that transmission lower between not only within our community, but not others coming in or others traveling away and bringing it back. And so that is kind of showing us that we are going to have, what we've seen is this much lower rate of hospitalizations. A lot fewer people will become infected over time. And so that's what we're hoping for, and that's what we're wanting to continue to do. And if you look at this map compared to California, it's projecting that our peak and our rise and cases and things like that will be later than the rest of California, because we have seen that increase of cases at a later than a lot of the urban areas who have been impacted in the beginning of this process. So if we were to all of a sudden stop doing as strict as we are right now, we could definitely start to see an increase in those cases. It might not be as high as what we're seeing right here on the chart, but we definitely could see that increase all of a sudden jump up and become to a point where it could overwhelm our system. And so that's the models that we've been looking at. There's lots of other ones we're looking and been sharing with our leadership and things, but this is the main one that we really wanted to share with our community to really help them understand why it's so important. That what we've been doing has been making it so that we're seeing that lower level of cases and hospitalizations, and we don't want to make sure that those sacrifices we've done have been in vain. We want to make sure that we're continuing to do those so that we don't all of a sudden have a huge peak of cases and a spike in cases where we become overrun.
All right, thank you very much, Daniel. I'd like to now open it up to Dr. Karen Ramstrom, who is going to talk to us a little bit about potential next steps.
Sure. Thank you, Kerri.
So, and thanks so much, Daniel. That was really helpful information. So I wanted to talk a little bit about our numbers today and where we're going from here. So we're really, really pleased to see the number of cases leveling off, and that's really largely due to the work of all of our community members really taking the stay-at-home order very seriously, our businesses who are taking it seriously and implementing prevention measures within their locations. I want to describe my thought process of how we go forward from here. These are initial thoughts, and we'll be having this ongoing dialogue. But we also at this point need to remember that the state stay-at-home order is still in place. Yesterday, the governor shared his roadmap to modify the stay-at-home order moving forward. And as the state order evolves, we're taking steps to thoughtfully plan and think about measures that will allow us some local control over how that roadmap plays out in Shasta County. So this is what I envision. For the coming weeks, we need to monitor the case counts to ensure the numbers continue at this sustained low level that we've been seeing lately. And in that interim, as we're monitoring those numbers and preparing for ultimately some gradual loosening of the stay-at-home order, we need to ensure certain protective measures are in place, and we're very confident about those protective measures to prevent a rebound of case counts and ensure that our hospitals can care for those who are getting sick. So, we don't want our numbers to go back up again. And so there's going to, this will involve, ongoing monitoring and revision of our practices, depending on what this looks like over the coming weeks and months. So, we need to remember that we still do not have community immunity to protect us from disease spread. And so these strategies are really, very important to kind of move forward in a stepwise fashion. So the protective measures that we're talking about involve a lot of planning, and I'm just going to talk through them a little bit. First of all, we're going to continue and improve our surveillance data to monitor the outbreak moving forward. We need to ensure the capacity to test all people who have symptoms with COVID-19, and there's a lot of work that goes into making sure that that's happening. We need to continue to ensure that we have capacity to investigate all of the cases, isolate those cases, identify their contacts, and quarantine and monitor those contacts for 14 days for symptoms and arrange for testing should symptoms develop. We need to make sure we have the ability to protect vulnerable groups, including older adults and individuals with medical conditions. And so what this looks like moving forward for those groups is going to be different than the general public. We need to ensure that all businesses, schools, and childcares can distancing within their locations. And then we need to identify triggers that'll tell us, nope, we need to go back to where we were before, to stricter stay-at-home and social distancing practices that Daniel was just speaking about. So to move in this direction, we're going to need to continue the physical distancing practices that have been in place, and then potentially consider other practices as we get out into the community more, such as wearing face coverings when we're out in public. So along the way, we're also knowing that the federal government is moving towards development of better medications. That's going to be necessary. We need to be able to take care of people who get COVID-19. And there's also a lot of work going into development of reliable serologic testing, which will help us to understand individual and community immunity. And that's really, really going to be an essential tool for us. We're not quite there yet, but that's moving along well. And whether or not we're peaking right now, we will experience other peaks. And so we're going to need to be able to revisit these measures as we're monitoring our data and seeing how this outbreak is evolving in our community. We can't really plan to go back to pre-COVID life as we knew it, really until we have a vaccine and we have the level of community immunity that will prevent widespread transmission in Shasta County. And so that's kind of our thought process right now. It's going to continue to evolve, and we'll be working with our community and partners and key constituents, including our businesses and others, to move this forward. So I just wanted to start that conversation, and we'll be continuing to talk about this moving forward. Thanks.
Thank you very much, Dr. Ramstrom. Did any of our spokespeople have anything to add before we open it up to media questions?
Okay, hearing none, we are ready for your questions.
I have a quick one from Dr. Ramstrom. You mentioned that the vulnerable groups would be treated differently than the general public. Do you know in what way what that would mean?
Yeah, it's a good question, Mike. So I think there's a few groups within there. One, we have to remember our older adults. More than likely, you know, as we think about maybe younger adults and children and maybe loosening things up a little bit for those populations, we're going to still want to keep our older adults at home. Similarly, people who have really serious and chronic underlying health conditions, they're going to need to continue to really be careful and protect themselves. And then lastly, our congregate setting. So, you know, one thing that I worry about as we open things up a little bit, that you know, all of us have would have increased potential to get exposed, you know, and so staff, for example, who work in congregate settings are going to need to be particularly careful to make sure that as they're going back to those work sites that that they're healthy and not having any symptoms of COVID. So those are the kinds of things that we need to look at, like how can we make sure as we're opening this up, we're doing it in a safe manner for those groups.
Thank you.
Hey, Kerri, were you going to give the stats today? This is Mike from the Record Searchlight.
Never ask. Thank you for keeping me honest, Mr. Chapman. Yes, we have, as of today, we have 25 confirmed cases. We had no new cases yesterday. We've had 744 negative tests, including 23 yesterday. We've got 8 people on isolation, 56 on quarantine, 12 have recovered. That was a big increase from yesterday. And we have had 3 deaths. We've also started collecting and reporting daily hospitalization numbers. Those are still kind of a work in progress, but as of yesterday, we had 3 folks hospitalized and a total of 7 of our 25 patients have had to be hospitalized. Thank you for that question.
All right, thanks.
Other questions?
I have a question about this new data that we've got here. Is this based on epidemiological data that's gathered elsewhere with this COVID-19, or is this based on the data here in Shasta County? And if so, has there been adequate testing for a reasonable sample?
Daniel, could you describe the methodology for this model?
Yeah, so this is using specific Shasta County data. It is still kind of, this one is still kind of in its beta form for county data, but no, this is definitely looking at our data to best project kind of those potentialities. And again, everything that's kind of under those shaded areas could be a possibility within that. That's that range of possibility. So it does show, in my opinion, an accurate understanding of what we do know with the testing that we have to the best of our knowledge. Of course, nothing is perfect, and this math and projections and things like that, but that's what we are looking at.
I have a follow-up question. This is Donnie Chamberlain regarding Daniel and the model that you laid out for us. Have you extrapolated the 2 various scenarios regarding deaths, the 2 lax versus strict adherences?
So the models that we've been looking at, a lot of them do not talk about how many deaths would be occurring in the populations. Their main focus is on that hospitalizations in the ICU or ventilators, different things like that. Again, with that high number of hospitalizations, you would then expect to see a certain percentage of those that would become deaths, but there's not a specific number in that at this time.
Thank you.
Yeah, can I ask, the COVID Act Now website, is that a public website?
Yes, it is. And I believe it was shared on our Facebook page so that you are able to then access it there, or you can, yeah, just type it in as well.
All right, great, thanks.
Stephen, just a bit of a simple follow-up to the question that you asked. These models, because we do have low numbers of people who have tested positive and hospitalized cases, a new case, a new hospitalization does change it. And so every time, not every time, but when we look at it over time, it will change, just because based on the low numbers that you described. So certainly there is no magic mirror that we can look into, but this looks like this is what we're working with right now.
With
Other
the
question?
Oh, I'm sorry.
Go ahead.
With the data that's been gathered worldwide with this COVID-19, has there been any change in the contagious, how contagious it is in terms of like the 6 feet, which seemed, I don't know, months ago when we heard to stay 6 feet away from each other, that seemed like just a wild guess. And is that still considered the optimal distance away from each other that we should be? And what is that based on? Is that based on particulate matter coming out of our mouths when we talk, or what is that? And has it changed at all?
So thanks for that question. So the 6 feet comes from what we know about pathogens that are transmitted by by respiratory droplets. So we know those are heavier droplets than airborne transmission. So those droplets can only travel so far before they kind of fall to the ground or land on the environmental surfaces. And so the 6 feet is, so usually, you look at sort of 3 to 4, 6 feet is pretty conservative. It's really a safe area to make sure that you're out of the vicinity of somebody from talking or speaking or singing or what have you, and their respiratory droplets landing on you. So that's where that comes from. It's sort of standard information known about that kind of disease transmission.
Do different strains of flu have different levels of contagion? I mean, is this based on all types of flu, or is this one more volatile than others?
So this is different than the flu virus, so different pathogens are transmitted in different ways. So for example, measles is airborne, and so we know that can travel further distances. And so people, it's very highly contagious. It's more likely to infect more people from one individual who has the disease. So with this particular disease, it's not, I guess, much different than influenza, but the thing with influenza is we have some immunity. With coronavirus, we don't. And so, but the way the transmission happens is the respiratory droplets. So yeah, for this virus.
Is it comparable to to other transmittable diseases? Since you say it's not actually an influenza, what is it like that we are accustomed to?
So good question. It's, I guess it would be similar to influenza. I'm trying to remember the data. I haven't looked at that for a while. So gosh, I've done that presentation so many times and it doesn't come to my mind right now. But so any kind of pathogen that is transmitted that way, whether it be influenza or other kinds of cold viruses, for example. And so, but there's other factors that go into the amount of communicability, like how sturdy is that virus, for example? How likely is it that it survives on surfaces? And so there's a lot of other considerations, and all of that information has been taken into consideration with the recommendations for both physical distancing, environmental precautions, environmental hygiene, all of that for the coronavirus specifically. I'm happy to share more details on that though with you if you like. I have some information I could send to you.
And also, Steve, another really good resource for that is the CDC's website. They've got all kinds of information about the disease and how it behaves. That might be helpful for you as well. Are there any other questions?
Yeah, I have one for Dr. Ramstrom. So with this model here, would it be accurate to say that the community is in control of whether we have this surge or not, and whether the hospitals may overload? Does the community control that factor then? Is it up to us to keep the surge away?
That is an excellent question. And we didn't talk about it. Daniel's done a lot of work in addition to this model he just shared with you. He's looked at several different models and applied those to our community, trying to figure out, they all have pros and cons and limitations. And so trying to figure out the best way that's to share this with the community. And that's why he shared what he did today, because it's very and easy to understand and digest model. The models are also influenced by, in particular, how well we are complying with stay-at-home measures or social distancing measures. And so depending on how well we're doing, just like in the model Daniel shared, it will change how steep that curve looks, how much disease transmission we have and how fast that happens. And so definitely implementing those measures, which is, like you said, is really up to our community members to do that, makes a difference. And so that's the whole idea. We know that when we don't have medications, we don't have vaccines, we have to use these what are called non-pharmaceutical interventions, which include social distancing, environmental cleaning, those kinds of measures to protect our community. And so that's exactly what we're doing. And that's what influences the shape of these curves and when they peak and how high those numbers go.
All right, thank you.
Donnell, I'd just like to.
I have a quick question.
Sorry, I just wanted to add on to what Dr. Ramstrom said. I want to thank the community. Our community has done an outstanding job of complying with the stay-at-home order, and that's why we're getting this excellent result that you see on the graph there. And our numbers, are a tribute to everyone's participation in helping keep our vulnerable adults, older adults safe, or people with chronic underlying illnesses. This, is something that we're going to have to sort out with the state. The state's working on it right now as to where we go from here, because if we stop doing what we're doing now, the situation will change and we will start seeing more cases. We were very fortunate in the whole North State, not just Shasta County, but the whole North State, that the outbreak had not really gotten very far before the stay-at-home order. So because of that, we've had a very small number of cases relative to the rest of the state. And that's been to our benefit. And so many of our people have been, saved from getting infected. And
I have
so I just want to point out that one of the reasons why we have the result that we have is because the stay-at-home order went into effect before our outbreak had gotten very far.
I also wanted to add that our disease investigators and our contact tracing team have been incredible in helping to keep this number down as well. Once a case is identified, those folks that are going out there and working to identify close contacts, issue those quarantine orders, that is making a very, very big difference. So all of those pieces together have really contributed to that lower level that we're seeing here. Donnie, you had a question?
Yes, Donnell, I'm sorry that I interrupted you during a pause. I apologize. So Daniel, that June 16th date was kind of startling for me. And I think there are so many mixed messages on a federal and state and county level. And the public is just itching to get back to, quote, normal life. So does that mean that we should hunker down longer? I mean, the president is talking about May to lift guidelines, and then different states are saying different things. So what is the public here in Shasta County supposed to do? We look to the county and we look to the state and then we look to federal. I mean,
So this is Karen. I'd like to address that. Daniel, feel free to chime in if you like, but so it's a good question. I think, as we've been looking at these models, we've been looking at them as a tool to tell us when are we done, and that's not really what they're used for. I think they're helpful to show what is the impact on our healthcare system, depending on what we do in our community in terms of social distancing and other measures, like the contact tracing and such. So, and home isolation and quarantine. So these are tools for us to plan at the healthcare system level. Largely, I mean, really, and for us to model and get a feel for, well, how much of a difference does it really make if we are implementing these social distancing measures? And so that's what I was sharing earlier, is kind of how we're going to move forward. Is we're going to actually have to monitor our case numbers, and as our case numbers go down over maybe a 2 to 4 week period, so we get a couple incubation periods in there. If we're pretty comfortable, then we, in a stepwise fashion, can start loosening a little bit of these stay-at-home restrictions, but only if we have those protective measures that I mentioned in place. So we need to make sure we still continue to protect those vulnerable groups. So older adults, people with medical conditions need to continue to stay home. We need to make sure that we're able to actually do case identification and contact tracing, isolation and quarantine for all of our cases. We need to make sure that we have best practices built into the way our businesses are working, and so that social distancing is built into the way when you go into a business, you are not in close quarters with other individuals. So all of those pieces need to be in place for us to start peeling off pieces of what we're doing. So for example, we might initially think about, can we allow small groups, right? Less than 10. That might be one of the first things that we do. Or can we even think about groups that don't seem to get as sick, so children and young adults, if there are maybe ways that they can go about having some normalcy in their lives, in ways if we can actually implement social distancing within the facilities and sectors that they're visiting. So that's kind of where we are, and all along we'll have to be monitoring what do our cases look like and have triggers identified that will tell us, oops, we're going back up, we need to back off again and go back to stricter stay-at-home interventions and social distancing measures. So that's kind of how this is going to play out at a state and local level. And because every community is different in the way that we're laid out, the way that we interact with each other, the way our geography, our density of population, it's going to play out a little bit differently in each community. And I think that's what the governor is getting at, is that it's going to have to be, they're going to give a framework, but it's going to have to be implemented at the local level based on what's happening at the local level, and with these sort of strategies built into how we're moving forward over time. Does that answer your question?
I've got a question. Since the
Kind of. I mean, I appreciate that. That's a good answer. I guess I was just looking at sort of.
Yeah, I don't think that there's a one date. That's the thing. I don't think that we can give we can't just give a date where, oh, good, we all can go back to normal. We need to do this in a stepwise manner because we don't have community immunity. We recognize it's not sustainable to keep doing what we're doing right now for a prolonged period of time. Yet at the same time, we need to have some of this built into the way we go about our lives over the coming months until we have a vaccine. We have enough community immunity to prevent disease spread. And so that's kind of where we are. And so it's going to be, every community is going to be a little bit different in how that they do this. And it might be, we might have to kind of go back and forth a little bit, and making sure that we don't let this get out of the bag, out of hand again, and then overwhelm our healthcare system. So we're going to have to be monitoring it really, really closely. And that's going to play out differently in every community. We do know that there's likely going to be other surges. And so we have to be prepared to then, really ramp up our isolation, quarantine, contact tracing, and maybe tighten up again, how much interaction we're having. So, and that's going to play out a little bit differently depending on the community and what you're looking at.
All right, I know today's press briefing has gone a little bit longer than we've been going usually because we've had some pretty extensive new information to share with you, but we can take another couple of questions if anybody has anything pressing.
Yeah, Kerri, I have a question. This is Mark Albert from North State Public Radio.
Sure, of course.
And I apologize, I wasn't able to hear the initial part of the hearing because in a another conference call, but could each of the representatives from each of the hospitals explain a little bit about or discuss how their current caseload is matching their preparations, and how many beds and how many ICU beds you currently have available? I know the outbreak is not, overwhelming at this point, and that's probably not a big concern, but we really would like to get that information.
I'm gonna go first, or I guess I'll go. So for preparation for us, like we said, over the last few weeks, our volumes have been decreased because of everything, people staying at home. We have been around 50 to 60% of our occupancy rate, which is much lower than what we're usually at this time of the year. I know you were specifically saying ICU. We've got a total of 22 beds in our ICU that we can go up to. And every day we're typically around 10 to 11. So we do have a fair amount to surge up to if needed. But we really don't, crossing fingers, hopefully don't see that happening anytime soon.
Robert, do you have an answer too?
Yeah, I got my microphone turned on. We have 43 ICU beds available to us. We've actually dedicated, our ICUs are split into 3 slightly different geographies. And one of the geographies, we've split that ICU in half to basically handle all of our initial COVID positive patients. So again, much like Mark shared, our volumes are off considerably. Surgical volumes for all of us are off drastically, probably 60, 70% of what we normally do. So right now we have lots of capacity and capability, but I think that just speaks to the success of the work that we've done here in Northern California. And as far as surge, we have the ability to surge up well over 350 beds, but that looks very awkward. So what's nice is the field hospital. So again, from our standpoint, when we start looking at the surge, instead of suggesting that we would put a patient in a non-traditional area, that's where the field hospital is going to be very helpful for us.
If you'll let me follow up. Well, I'm wondering how each facility is managing the demand and supplies of PPE. I know it's been a huge national issue, and hospitals are having to, they don't know when they're going to get resupplied, and they're trying to stretch out their supplies, at least just generally. And I know that the nurses union has been active in trying to raise that as an issue, saying that people's safety is being put at risk because they're attempting to not necessarily ration, but prolong the usage of the same PPE. I'm wondering how and of course, there's no easy answer, because if you don't ration now and there's a rush and you don't get the resupply, you're facing a nightmare scenario of having to treat people with nothing. But I'm wondering how you're threading that needle.
You should have been on the call the last 3 weeks. I think all of us have a certain level of confidence in our supply chain. So my pat answer will be, we've had the PPE we need as we've needed it. We've never put our staff in a situation where they don't have what they need. Part of the challenge with our system of healthcare is that consumers want what they want when they want it. And I would even suggest at times that staff want what they want when they want it. And in the case of a pandemic like this, where the global supply chain is interrupted, that's where we have to be somewhat strict on using the right measure at the right moment. So I think our labor partners would have to agree that we've had those supplies, the correct supplies at the right moment. Has it gotten thin at times? Absolutely. But that's because this is a global pandemic.
And to add to that, I think one of the successes we've had is being able to start early in our, rationing would be a very poor word. It would be controlling the allocation of them. And being able to start that early before we saw this massive surge, we've been able to ensure that the staff have all the available supplies they need at the right time. So similar to what the community has done with their stay-at-home order very early on in this event, us making sure that we have control over our supplies early on has allowed us to make sure that we have enough and making sure everybody's safe.
I also wanted to give Valerie Lakey an opportunity to answer those questions as well.
We are up here in Fall River Mills in a critical access hospital. This may not work. We're together in the same room. Okay, so just to address the PPE really quick, we, like Robert and Mark mentioned, this is something we prepare for and we've been planning, and we are required to have processes in place. So our staff is very comfortable with the situation that we're in, and we monitor our PPE daily. We use the burn rate calculator. We work very closely with the California Hospital Association. We're monitoring things. So this isn't something that just jumped on us. It's something that we plan and prepare for. As far as our capacity at our hospital, we are critical access. So we only have 16 beds and we have no ICU. So we work very closely with our partners in Redding. We can accommodate up to 25 in a surge, and we can convert 4 rooms to negative pressure. So we would take care of any COVID patients that didn't require the extra. It would be more along the lines of how we would treat a patient in normal circumstances. So if we could care for them, we would keep them and care for them. If it's something that is more a higher acuity, then we work with our partners outside of the area and hope that we can transfer. We realize that may not be possible, so we have plans in place to try to accommodate any potential surge. So as I said, the thing about it is that hospitals have to be prepared. We're required by law to have plans and to have surge plans and to practice these plans. So we are as prepared as we can be, and we work together, the 3 of us, to make sure that we can take care of our community the best that we can.
Awesome, thank you, Val. Okay, do we have any other pressing questions today? Okay. Any other questions before we sign off for the day? Okay, as always, we will continue to post updated news on our Facebook page as needed, and then also in our daily update that comes out around 6 o'clock every evening on our Facebook page, and then it also goes out to the media. And we will see you all again on Friday morning at 11 a.m. Thank you all for participating. Have a great day.